Good morning, one and all. The topic for today's discussion is on orthognathic surgery. And in orthognathic surgery, we'll be covering about the maxillary osteotomy procedures. Orthognathic surgery. Ortho means straighten and gnathic means the jaw. So, orthognathic surgery means straighten the jaw in the sense whenever there is a deficiency of the jaw or prognathism of the jaw, what we do is we try to correct the jaw, either the upper jaw or the lower jaw, by doing a surgery to correct the underlying skeletal discrepancies. So, orthognathic surgery is aimed at aesthetic correction of jaw deformities and also to restore the form and function. Orthognathic surgery predominantly is done for correction of the aesthetics of the face. Imagine someone is coming with a prognathic upper jaw or a prognathic lower jaw. So the aesthetics would be of main concern. Whenever we see these patients, they are psychologically affected. They do not want to have a social life because they feel that the face is not suited, socially accepted. Certain other patients are happy, certain patients become psychologically stressed. So orthognathic surgery is aimed at aesthetic correction of the jaw bones and also to restore the form and function. How does it restore the form and function? Imagine patient is having a class 3 mandible. He cannot bite in his front teeth. There will be occlusal discrepancies. The maxillary arch and the mandibular arch will not correlate to each other. Chewing efficiency will be less. So when we do a surgery, it restores the form and function as well. By definition, it is the art and science of diagnosis, treatment planning, and execution of treatment by combining orthodontics and oral and maxillofacial surgery to correct the musculoskeletal, dento-osseous, and soft tissue deformities of the jaws and associated structures. Diagnosis and treatment planning is very important for orthognathic surgery, and also combining with orthodontics give you the best of results. When we're talking about orthognathic surgery, it is ideally about treating the skeletal deformities in the maxilla and in the mandible. But when you're looking at the face, we cannot just isolatedly see only the maxilla and the mandible or the entire skeletal bone. We also need to take into consideration the temporomandibular joint, the occlusion, the muscles which is overlapping the skeletal bone, and over the muscles we have the subcutaneous tissue and the skin. All these together forms the face. So when we are talking about orthognathic surgery, it is not just about doing some surgery in the bone. We need to keep in mind about the temporomandibular joint, about the teeth, about the muscles, about the skin, the subcutaneous tissue, and also certain micro detailing of the face. So all these compromises the face as a whole. How do we analyze face? When we see the patient from the front, based on the facial proportions, the upper third, middle third, and the lower third, the horizontal and the vertical proportions of face. Here you can see how we can clinically see the patient. Certain times during examination, we also mark certain points on the patient to analyze the upper third, middle third, and the lower third, and also the vertical proportions of face. All of these clinical examinations give you certain characteristic points, and that has to be carefully noted down in your case sheet. So we saw about the facial proportions in the front view. In the side view, we call it as the facial profile analysis. the sense how the upper jaw is positioned to the cranial base, how the mandible is positioned to the cranial base, and beyond that, the soft tissue, how the upper lip is positioned, how the nose is positioned, how the chin is positioned, what is the chin throat angle, and various other soft tissue analysis is also been done. Let's go back to basics. What is normal, ideal, and gold standard? The dental objective wise, it should be an ideal overjet of 2 to 3 millimeters, ideal overbite of 2 to 3 millimeters, a coinciding midline, class 1 molar and canine relationship, tight contacts, complete leveling and alignment, and functional occlusion. That's the goal of every orthodontist. Let's understand the term overjet and overbite. Overjet is the horizontal overlap of the maxillary incisors, and overbite is the vertical overlap of the maxillary incisor. Whenever we talk about the occlusion, not everyone can have an ideal occlusion. It's very tough because these are the lists of having an ideal occlusion: a coinciding midline, dental midline to the facial midline, no crowding, spacing, rotations, overjet 2 to 3 millimeters, correct crown angulation and inclination, class 1 molar and canine relationship, and a flat or slightly upward curve of speed. So that is an ideal occlusion. Class 1 malocclusion, where we can see that the maxillary first molar, the mesiobuccal cusp, comes in contact with the lower buccal groove. In class 2, the distobuccal cusp comes in contact with the buccal groove. And in class 3, the mandible is prognathic, thereby the lower jaw is forwardly placed, therefore the maxillary first molar is behind the mandibular first molar. Class 2 division 1, when class 2 molar relationship is present with proclined upper central incisors, and then class 2 division 2, class 2 molar relationship and the upper central incisors is retroclined. So that is class 2 division 1 and division 2. Also we have class 2 subdivision. When do we call class 2 subdivision? If a patient has a class 2 molar relationship on the right side or in the left side, and then a class 1 molar relationship on the right or the left side. In the sense, one side it is class 2 and the other side it is class 1, we call it as a class 2 subdivision. Class 3 molar occlusion, similarly, the mandible is forwardly placed, thereby the lower molar is forwardly positioned, and we call class 3 subdivision whenever there is a class 3 molar relationship on one side and a class 1 molar relationship on the other side. Quickly we can see this picture showing both the class 1 molar and the canine relationship. Very important in terms of orthognathic surgery because we need to check on the occlusion when the patient comes to us. Sequencing orthognathic surgery. Clinical examination, history taking and evaluation is of prime importance. Thereby we can come to a conclusion of a good clinical diagnosis. Whatever we have in the case sheet, we give a clinical diagnosis. Then we get the X-ray investigations done. We correlate the clinical findings with the radiological finding and then give a radiological diagnosis. We can also analyze these X-rays, the lateral CEPH, the PA-CEPH, and also CT scan have been done for these patients recently. All these radiographs can be assessed based on the standard value which has been available in the literature. With these available analysis and CT and X-ray evaluation, next would be the model surgery. Whatever surgery we are planning to do on the patient, we try to do it with the cost. We'll be discussing about that detail in the later slides. and then finally the surgical execution on the patient. We're discussing about the lateral ceph. Lateral ceph gives us the idea about how the maxilla and the mandible are being positioned to the cranial base. There is also a soft tissue shadow, so we can also do the soft tissue analysis. Various analyses are there. Usually we do the COGS. It's called as cephalometric analysis for orthognathic surgery as described by Burstone. So there is a hard tissue analysis, there is a soft tissue analysis. We compare with the normal values. The normal values are separate for male and female, so we correlate and compare and then give a final outcome or the final problem list based on the x-rays. Manually we can do the Burstone's analysis, the PSF analysis. Now in the digital era, once we get a CT scan done for these patients, we can also load the CT scan into the computer, and then there are certain softwares we can give us these analysis being done digitally. So then we can have a CEPH which is being traced digitally, we can have a PSF traced digitally. So what we do with these tracings? Something called as a CEPH prediction tracing. So we draw the outline of the soft tissue, we draw the outline of the bone, and then imagine in this particular patient the maxilla is deficient or the mandible is deficient. So what we do, we cut only the maxilla and slightly move it forward along with the soft tissue. And then if the mandible is deficient, we cut the mandible and slightly move it forward to get the desired occlusion, desired soft tissue corrections. So we do a prediction tracing in the cephalometric sheets. Why this is done? Because we can have multiple of plans which we can do it in the paper. So we do all these combinations and find out what is best for the patient. So the prediction tracing can be done both for the lateral ceph and also for the PSF. So you can see here how the prediction tracing is being done. You can see that it's a case of a facial asymmetry. You can clearly see that how the face, there is an asymmetry in the face and how it is being corrected to the best possible way. So we clinically evaluate the patient, we get the CT scan, we can evaluate the patient, we get the lateral ceph, we can evaluate the patient, we get the PSF, we evaluate the patient, and also we take the model and evaluate the model. So all these things are done. Now we know about face bow transfer. Face bow transfer is done in order to record the position of the maxilla to the cranial base. So we have the Hanau articulator or SAM2 articulators. So all these articulators can record the position of the maxilla to the cranial base. So it has been, whenever there is a maxillary orthognathic procedure, face bow transfer will be done and the models will be articulated in a Hanau or a SAM2 adjustable articulator. So this is how we can see that how the patient's maxillary arch to the cranial base, that particular angle is recorded in the face bow and then is exactly transferred to the articulator. Now in the articulator, the inclination of the maxilla will be exactly oriented to the patient. Now the articulator is prepared, the maxilla mandible casts are put into place. Now whatever surgical plan which we have tried upon the lateral ceph, whatever surgical plan we tried in the PSF, so we did ceph tracing, prediction tracing, so that plan will be transferred to the models. So it is called as model surgery. So for this patient, first the maxillary model is being cut and repositioned. then the mandible is cut and repositioned, then the desired occlusion will be put forward. Okay, based on these positions, we prepare something called as the occlusal splint, and this occlusal splint will be used in surgery. So this is the sequencing of orthognathic surgery: clinical diagnosis, radiological analysis, prediction tracing in the lateral ceph. The same plan what we did in the lateral ceph prediction tracing, we do it in the model. It is called as model surgery. We prepare the splint and use these splints in the intraoperative surgery. So this is the sequencing of orthognathic surgery. So this is the conventional way of doing. Now with advent of science and technology, we can do all these. The ceph analysis can be done in the computer. The model surgery prediction can become done in the computer. We can 3D print a occlusal splint. So all these can be done in a digital way, or digital planning can be done. So that is how the same cephalometric tracing or the PSF analysis which was done in the clinic by the doctor or the clinician now can be done by means of using a digital platform where we can exactly do whatever changes we need to do to the maxilla, whatever change we need to do to the mandible. So all these planning will be done simultaneously. As I was telling you, orthodontics also plays an important role. So something called as pre-surgical orthodontics. In pre-surgical orthodontics, what they do, they completely align and level the teeth. The decompensation will be taken care of, arch coordination, pre-surgical orthodontics objectives in the transverse plane, pre-surgical orthodontic objective in the vertical plane. So all these will be done prior to surgery. So after this, once the patient is ready, patient will be shifted to the surgical unit, then they will do the surgery. And then final settling of occlusion will also be done by the orthodontist. Jaw deformities of the maxilla. It can either be a vertical discrepancy, in the sense treating a long face, an anteroposterior discrepancy, for example a prognathic jaw, or a retrognathic jaw, and transverse discrepancy, whereas there is a narrow maxillary arch. So any of these problems, three-dimensionally, we can do the surgery and then correct it. Let us see how these surgeries have been performed. Coming on to maxillary surgeries, so we have segmental osteotomy of the maxilla and total maxillary osteotomy. You can go through the slide. So segmental osteotomy, in the sense even a single tooth osteotomy can be done. Corticotomy can be done so that the tooth movements can be fastened, and then something called as anterior segmental maxillary osteotomy, posterior subapical osteotomy of maxilla. In total maxillary osteotomy, you have Leaford 1 osteotomy, Leaford 2 osteotomy, and Leaford 3 osteotomy. In today's class, we will be discussing about anterior segmental maxillary osteotomy. We will be discussing about Leaford 1 osteotomy, and then rapid surgery assisted expansion of the maxilla. Whereas Leaford 2 and Leaford 3 osteotomy is not within the scope of this lecture. Vertical excess of maxilla. So when do we call the maxilla has grown vertically more? For example, the patient might have a gummy smile or a long face. The lower third face will be longer. Now let us see an example. Here you can see the incisal exposure is more. Patient is having a gummy smile, and when we see the occlusal records, you can see that the overjet is more. So these are the typical characteristics of a vertical excess of the maxilla. So what are the problem list? Increased incisal exposure, gummy smile, increased lower facial height, and increased overjet. So that's a classification for vertical maxillary excess. And how do you treat it? Between 2 to 4 millimeters, orthodontic intrusion orthodontic and periodontic therapy. And when the incisal exposure is 4 to 8 millimeters, that is when we go into treat the skeletal discrepancy. We do the orthognathic surgery. And beyond 8 millimeters, definitely it's an indicator for orthognathic surgery. So let us see about anterior maxillary osteotomy, which was first described by Cornstalk for correction of bimaxillary protrusion, marked protrusion of the maxillary teeth, for correction of anterior open bite. Anterior maxillary osteotomy techniques, there are 3 techniques as described by Wanderer, Wasman and Cooper. So these are the 3 techniques. Almost all these techniques by Wasman, Wanderer and Cooper are almost the same because it's all targeting the anterior maxilla. In the sense, it is the surgery which has been done for the premaxillary area. If there is an excess in the premaxilla, from the premolar to the incisor, any excess, we can extract one of the teeth. Maybe the first premolar is the preferred teeth of extraction. We extract the teeth, utilize that space and push the anterior maxilla backward. So 3 techniques, Wasman, Wanderer and Cooper. Each of these techniques vary based on the incisions. For example, in Wanderer's approach, there is a palatal incision which has been done, and then right through the palate they cut the bone. Okay, so that's the technique. We extract the teeth, using that space, we remove that bone and then push the premaxilla behind. So that is how exactly the anterior maxillary osteotomy is done. You can see the clinical picture. So the extraction of the first premolars, using that space, the bone is completely removed. Then when making these cuts, we make the buccal cuts, we also do the palatal cuts. As we saw in Wanderer's approach, where there is a palatal incision, the technique what we follow nowadays is the Cooper or Epcos down fracture technique, where there is no palatal incision. We tunnel the palatal mucosa and then make the bony cuts. You can see certain surgical pictures as well. For this patient, the problem list is the incisal show the gummy smile and increased overjet. So an anterior segmental osteotomy was done for this patient, in the sense we extracted the premolar, utilized the space and then set the premaxilla backward. So, and that's the result we can achieve for this patient. So pertaining to the maxilla, the problems can be, we can have an open bite, increased overjet, certain functional problems, long face, aesthetic problem. So all these problems can be there pertaining to the maxilla. So the anterior maxillary osteotomy is done for the premaxillary excess. If the whole maxilla is in excess, the vertical excess of the maxilla, we do something called as a Leaford 1 osteotomy, where we do osteotomize the entire maxilla from the cranial base and then position the maxilla in the most preferred position. So we'll see how it is done. So here we can see incision is placed right from one side first molar to the other side first molar. Bony cuts will be made right from the nasal aperture to the pterygoid plates, and then we do a disjunction where the maxilla will be disjuncted from the cranial base. Okay, we can see certain pictures how these bony cuts are being done and what are the necessary precautions which has to be taken. When we are placing these bony cuts, we need to isolate carefully the nasal mucosa. Then we have the teeth. So we need to make the bony cuts 5 millimeters from the tip of the roots. So when we do these bony cuts, at the posterior end we have the descending palatine artery. So once we make the bony cuts, we can mobilize the maxilla completely from the cranial base. Okay, so that is Leaford 1 osteotomy. So whenever there is a vertical maxillary excess, whenever there is an horizontal excess of the maxilla, once we disjunct the maxilla from the cranial base, from the pterygoid plate, what happens is in all the 3 planes, we'll see in the pictures in all three planes we can correct the maxilla. We can either advance the maxilla, we can either take the maxilla backward, we can take the maxilla upward, we can downgraft the maxilla. So all these corrections can be done. You can see that how the bony cuts, the red line marks how the bony cuts have been done. Okay, the maxilla can be down fractured, and then you can also make the cuts in the pterygoid region, and then using a pterygoid chisel, we disjunct the maxilla from the pterygoid plates. We know that the pterygoid plates is part of the sphenoid bone. So we disjunct the maxilla from the cranial base. So when we are doing all these things, we also need to be aware of the vascular anatomy, the neurovascular bundle anatomy. So all these things we should remember. So once the ideal position is being fixed, we fix the maxilla in the ideal position with these plates using the splints. So once that is done, we can give a good wound closure. Okay, very important, all these steps need to be done with a precise manner. So when we are talking about completely doing a disjunction of the maxilla from the cranial base, we need to understand how the blood supply will be there for the maxilla, because we are completely making a through and through osteotomy in the maxilla. Certain biological studies were be done and put forward by Bell. They are the pioneers of orthognathic surgery. They had done this research using the rhesus monkey. Okay, so they made these osteotomy cuts in the monkey, in the maxilla of the monkey, and then they tried to analyze the neovascularization, or how the vascular channels were formed after surgery. So after all these research, okay, Leaford 1 osteotomy is being done, and then we can precisely plan these surgeries and then execute the surgery. Certain clinical pictures, how the osteotomy cut is being done, okay, and how it is being fixed. Another important concept I was discussing about is the three-dimensional adjustment. We can either rotate the maxilla, take the maxilla upward, downdraft the maxilla, bring the maxilla forward. So for any of these discrepancies, we can do the surgery and then correct it. As I was telling repeatedly, good clinical examination, good prediction tracing, good CT or X-ray evaluation, and then exactly what you predicted, you need to be doing that on the table. Okay, then the occlusal wafer, you can see that how the occlusal splint is in position, and then the maxilla will be fixed. You can see that how the maxilla is being fixed using 4 plates, 4 L-shaped plates, so that we can give a good stable fixation of the maxilla. We can see certain pictures of the patients. You can see that how there is a concave face, deficient maxilla, obtuse nasolabial angle, and a concave face. And then immediate after surgery, so this is on the first post-op day, you can see how the concave face, you can bring the maxilla forward. Okay, this patient doesn't have the maxillary anteriors, so if we can give the maxillary anteriors, the lip support will be improved. So you can get immediate results with orthognathic surgery. You can also see another patient. You can see how there is no closure of the lip, there is incisal exposure, and immediately after surgery, if this patient is slightly, the swelling is also present, maybe 1 or 2 months after surgery, you can see immediately all the incisal exposure, the vertical excess of maxilla, anterior posterior excess of maxilla, all these things can be corrected, and once it is done, you can see how the chin looks more prominent, how the patient is more positive. Okay, you can also see yet another patient of a cleft maxilla, where the maxilla doesn't grow properly in a cleft maxilla. So even for these patients, we can do the Leaford 1 osteotomy and advance it. You can see that always these procedures are being done in correlation with an orthodontist. Okay, the third thing what we are going to see is a transverse discrepancy. We saw how we can correct the vertical excess of maxilla, how we can correct the anterior posterior excess or retrographic maxilla anterior posteriorly, and transverse discrepancy. Certain patients will have a very narrow arch. So in these cases, imagine if it is an adult where orthodontic expansion of the maxilla is not possible. Again, what we can do is we can do a surgically assisted maxillary expansion. Similar to Leafort 1 osteotomy, we make the Leafort 1 osteotomy cuts, and additionally what we do is we also split the maxilla along the maxillary suture line and then open up the midline so that we can correct the transverse discrepancy. Okay, so this is how you can see that how the Leafort 1 osteotomy cuts are made, and then through the midline we make the osteotomy cut and then make the maxilla into two pieces. So what are the armamentarium required for these surgeries? We need to have the osteotome, the mallet, the surgical saw, the surgical burrs, retractors, plates and screws. Okay, so with these armament, and then the regular surgical, we need to have the BP blade, handle, periosteal elevators, all these allied instruments for the surgery. Talking about complications. Surgery has its own complications like pain, swelling, plates and screws can get infected, intermaxillary fixation. Immediately after surgery, we need to do the intermaxillary fixation in the sense patient cannot have solid foods or semi-solid foods immediately after surgery. They need to be on liquid diet, and chances of infection can happen, relapse can happen, iatrogenic injury. Okay, rare cases can result in blindness, unfavorable fractures, the surgery itself can fail. As a surgeon, we need to take all the necessary precautions for these patients because it is an elective surgical procedure. It is not a life-saving procedure, or it is not a must to do surgery. It is an elective procedure, so as a surgeon, you need to be cautious in all these aspects. You need to explain to the patient because overnight, the face of the patient is going to change. The patient has been living with the face for past 20-21 years, and then all of a sudden do the surgery, and then the patient's facial profile will change. So you need to mentally prepare the patient as well. The patient surgery is successful, patient is very happy, patient will not complain about all these complaints, that they will have swelling, pain, bleeding gums, wires here and there, intermaxillary fixation. The patient will not at all complain if the surgery is a good success. Certain small discrepancies than what the patient expected, it's always going to be tough. The surgeon need to be cautious and then plan for the patient, not just with the radiograph. You also need to sit down with the patient, talk with the patient, and then understand what they want and what will be the surgical outcome. So with this, we come to the conclusion of maxillary orthognathic procedures. So for this young lady, okay, she's just 14 or 15 years of age. So because of her appearance, she was not positive enough. She was not going to school or college. She was having tough times. So after surgery, she all became positive, and then the whole world looked new to her. Thank you. That's it for today's class on orthognathic surgery, maxillary orthognathic procedures. So we discuss about Leafort 1 osteotomy, we discuss about anterior maxillary osteotomy, we discuss about when to do these surgeries, what are the complications which can happen, what are the techniques to be followed, and how it can be sequenced. Thank you.